Good morning, Ginny Bello with the Legislative Analyst's Office. I'm actually going to be speaking from the first handout that was presented by Mr. Su titled Overview of the MCO Tax, Selected Other Tax Increase Options and IHSS Issues. So I'll just take a moment while you locate that handout and turn to page 11. And just by way of background, we were asked by the committee to present some background on the In-Home Supportive Services program and some history of some of the reductions that were implemented or enacted in that program during more tight fiscal times to provide some context and help paint the picture for how the 7% reduction in hours that was in place in 2014-15 came to be. So just by way of background, the In-Home Supportive Services program provides various services to eligible aged, blind, and disabled recipients to assist them in remaining in their own home rather than being placed in a nursing home or in a higher level of institutional placement. The IHSS providers are selected by the recipient and they help with tasks such as bathing, dressing, cooking, these activities of daily living. Recipients are eligible to receive up to 283 hours of services each month. That breaks down to roughly 9 hours a day, but the average recipient receives 99 hours of services per month, which is between 3 and 4 hours per day. And to be eligible for in-home supportive services, you have to meet income eligibility requirements. You have to be low income. And you also have to have a need for the service, and that need is assessed by a county social worker visiting the home and conducting an assessment of your impairment levels and determining the amount of hours that would be appropriate for your situation to assist you in remaining at home. You also are required, the recipient is required to secure a health certificate that says that but for the provision of IHSS services, they would be at risk of being placed in a skilled nursing facility. Because the In-Home Supportive Services program is a Medicaid benefit, it does receive federal funding through the federal government. Just as an idea, for the 2015-16 year, the total cost of the program is a little over $8 billion. 1.8 of that is coming from the state general fund. About $1 billion of it comes from the counties, and the remainder comes from the federal government. The estimated caseload for the program is about 467,000 for 2015-16, and that care will be provided by just over 400,000 providers. As I mentioned, the recipient is the employer for purposes of hiring and firing and directing the care. So they select that provider. The providers the wages of the providers range by county, with some counties paying the minimum wage and others paying upwards of $13 an hour. There really is a range. But at the end of the day, the state participates in IHSS provider wages up to $12.10 per hour. So turning now to page 12, as I mentioned, we were asked to present some history of previous reductions to the In-Home Supportive Services program. And I thought for context, it would be helpful to sort of lay out the categories of reductions that were attempted or implemented starting in about 2009-10. So they generally fall into 4 categories. The first is service reductions, and that sounds exactly like what it is. It would actually reduce the number of hours in-home supportive services recipients would receive. So a policy that fits into this category, that 99 average hours I mentioned earlier, would presumably be less if you implemented a policy that reduced the hours. Another strategy was to tighten eligibility, which would essentially cut the caseload of the program. There were also provider payment reductions. So as I mentioned, currently the state participates in wages up to $12.10 per hour, but a reduction that fell in this category would reduce that level of state participation to some other level. A final strategy was to increase the federal funding for the program and thereby reducing the general fund cost to administer and provide the program. So turning to page 13, there's a table, and you'll see in that table, we sort of tried all of these different strategies or a combination of them between 2009-10, 10-11, and 11-12. And what you see in this table is some of the major policy changes that were enacted during those years in the In-Home Supportive Services program. It shows their estimated solution value at the time that the policy was enacted, whether or not the policy was implemented, and for those that were not implemented, why weren't they implemented? Just one cautionary note on the estimated solution value. It's really here to help illustrate the level of funding, the level of savings that was attempted to be achieved in those years to help us understand how we ended up with the 7% reduction. So once those policies were implemented, or in some cases weren't, those numbers likely changed. So I think I could answer questions on any of those policy changes that you may be interested in, but I think in the interest of time, I'm going to focus on the ones that are most relevant for the 7% reduction to help us understand how we got there. And to do that, I would just call your attention to sort of the third column from the left, the one that indicates that the policy was not implemented due to litigation. And the first proposal or the first policy that was enacted that fits into that category is the Functional Index Service Reductions and Eliminations in 2009-10. And that was a policy that was enacted that would essentially increase the threshold for entering the program. So those folks that qualified for IHSS would have to be assessed as having a higher functional need for the program. And it did another thing where even once you were in the program, to qualify for one of the menu of services, you had to demonstrate be of the highest need. That policy was never implemented. The state was sued, and a federal judge issued an injunction that prevented the implementation of the policy. The second one was also in that same year. It's the reduction in state participation in provider wages. And this was a policy that would reduce that $12.10 that the state currently participates in wages down to $10.10. And similarly, that policy was not implemented due to a federal court injunction. And the final one I would call your attention to is in 2011-12, and it's the triggered 20% across the board reduction in hours. And that would do what it sounds like. It would reduce the service hours for in-home supportive services recipients by 20%. It allowed for some exceptions and also a process by which you could get the hours restored. But at the end of the day, it also was not implemented due to a federal court injunction. So turning to page 14, as a result of all of this pending litigation, the state was not achieving any general fund savings, and there was quite a bit of uncertainty from the perspective of the recipients who weren't sure if these policies were going to be put in place, and if so, when. So as a result, there was a March 2013 settlement agreement reached between the state and the plaintiffs, which essentially did four major things. It repealed those three enjoined policies, and then replaced them initially with a one-time 8% across-the-board reduction in hours that was in place in 2013-14. So recipients during that year received an 8% reduction in their authorized service hours. And then beginning in 2014-15, it implemented a 7% across-the-board reduction in hours, which would be ongoing unless, and this is sort of the final tenet, there was some sort of alternative revenue source that could be secured to offset the general fund cost of fully or partially restoring the 7% service reduction. So turning to page 15, we were asked to just give an idea of what the 7% when it was in place meant for an IHSS consumer. And so for your average consumer who was receiving 99 hours a month, that meant essentially about a 7-hour reduction in their service hours. For one of those maximum hour recipients at the 283 level, they would experience a roughly 20-hour reduction per month in services. To operationalize the reduction, because the IHSS recipients are the employer for purposes of hiring and firing and directing their care, they were given the authority in statute to direct their provider in how they would prefer the reduction to be taken. So maybe they would do less housework or less meal prep or less bathing. Those types of things were something that was left to the consumer to direct. Finally, I think on page 16, we've sort of covered it. In the spirit of the settlement agreement, the governor's budget did include a restructured MCO tax to provide for the restoration of the 7%. As you know, the enacted budget did not include that and instead included one-time general fund for this purpose with the special session to look into a permanent and sustainable plan to keep the 7% restored ongoing. Just as an update, it being July 2nd, we are aware that the hours have been restored, recipients were notified, and the counties were notified beginning in June, and so that is occurring.
Thank you. Why don't we do this, before we move on to Jason Cisney, why don't we ask questions for this particular panel, because I think Jason's going to deal with additional revenue sources. So I think Senator Monning had his hand first. We'll go with Senator Monning.
Thank you, Mr. Chair, and thanks to this panel as well for helping with our understanding of sometimes elaborate arrangements here. My first question for Mr. Martin goes to the developmentally disabled. Some of the data there of the objective of transitioning residents in developmental centers to community-based support. Has your research revealed, or do you have access to data of the rate of the closure of provider homes that's been happening over the last couple of years? And are there sufficient provider homes available to achieve the transition of roughly 1,000 residents into community settings?
I don't believe at this time there are sufficient provider homes available, but the department is in the process of developing additional homes for people who are moving out into the community. My understanding is that part of the funding that the legislature provided was in order to begin the development of that housing. And I think you asked me a question about data.
Correct. Of closure, of the rate of closures of provider homes.
I would have to ask the department if they have that data available. Would you like me to do that for you?
Yes, that would be helpful. And related to that, do you know the rough difference in cost per resident from developmental center to a community-based support home?
Well, generally, we have very complex cases in the developmental centers, and we have closed down Agnes Developmental Center and Lanterman Developmental Center. And generally speaking, the cost of moving those people into the community, they're going to be higher cost on average, although it can range quite a bit. I think between $75,000 and $300,000 a year for placements from certain people from Lanterman Developmental Center. But the cost can range quite a bit for the developmental center people who are moved into the community. At the same time, we have some people who are never placed in developmental centers who would also be in that same cost range.
Right. But is it a fair statement that the cost per resident, there will be a savings with the transition from developmental center to community-based?
We believe there will be, based on an analysis that we did looking at the cost per bed in the developmental centers, which is running around $500,000 a year. And then we looked at data regarding the people who'd moved out of Lanterman Developmental Center. And again, their costs on average was between $75,000 and $300,000. Now that was just for a select group that we had 1 full year of data on. But generally based on that, we think it, in the long term, after you make the investment in developing the community resources, it will be cost effective to move those people into the community.
Right. And again, assuming there are sufficient facilities to achieve that transition. And then just a final question on this area. When local regions, municipalities raise minimum wage, do the developmental centers, the vendors, does their provider rate increase commensurate with the increase in minimum wage?
You mean for the regional center vendors?
Right.
Yes, they do receive an increase that's passed through to the vendor based on the number of minimum wage employees that they have to cover the cost of that minimum wage increase.
Mm-hmm. And it's fair to say that a number of staff in these facilities are not being paid more than minimum wage. Is that an accurate statement?
I know there's a significant number of staff who work for vendors who that receive minimum wage.
Thank you. And then if I could, Mr. Chair, just a question on the IHSS information. the data shows roughly 67,000 recipients. Any sense of, has the state calculated, do you have access to information that would show what would be the increased cost to the state if we weren't providing the in-home support service? In other words, a percentage of these residents, I assume, would require nursing care or some kind of facility care if they weren't provided this care in their home. Is that an accurate statement?
I think it's a good question. I think it's one everyone sort of grapples with this program is sort of, but for it, what would be the cost in the skilled nursing facility? And I think the challenge is that in the program, you don't have to qualify for a skilled nursing facility to be in the in-home supportive services program. So presumably without the program, some portion of recipients would end up in a nursing home, but some wouldn't. And it would depend both on sort of their level of impairment and also their own social situation. Do they have a family support network that is able to stay home with them? So it's a really difficult question.
Any rough estimate of what percentage of that population would absolutely require
I think I think there may be some proxies. In the last couple years, the department secured some federal funding for what's called the Community First Choice option through the federal government, which required that for an enhanced federal matching for this certain population, you would have to show that this population was at risk of being placed in a nursing facility, and I think the department may have some of that detail. I'd still be sort of cautious about drawing too many assumptions from it, but I can definitely follow up with staff on who of the program fits into that Community First Choice population, and if that's a good proxy or what would be sort of the cautionary notes to include with that and get back to you.
Thank you. And then the final question, that the range of compensation for in-home support service providers, is it fair to say that the majority are being compensated at a minimum wage rate, or is there variance in compensation rates?
Yeah, there's quite a bit of variance, and I'd have to look at the data also to see, could you say that the majority are getting the minimum wage? And it's changing as the minimum wage increases. The share that are getting paid the minimum wage may also be increasing. So it's something I'll have to follow up with you and look at the individual counties and the number of providers in those counties and let you know kind of the breakdown.
Great. Thank you. Thank you, Mr. Chair.
Yeah, you had asked a question that you were supposed to respond to. I believe we have most of the directors here. If we can get them to come up, then maybe it'll answer the questions for whether the Department of Social Services, the various, I don't know if they're available or here or not. And then you can answer, or you can get a response?
I had one point of clarification I wanted to make to an answer I gave to Senator Monning, and that is that they adjust the minimum wages if you have a state adjustment to minimum wages, but we don't adjust wages for regional center vendors if it's a local increase in the minimum wage.
Okay, thank you. That's helpful, but I think perhaps important to figure out the broader economics of maintaining these facilities in a region where there may be a higher minimum wage. We've heard stories of somebody who's developed a relationship with a resident, a supportive relationship, and they end up leaving for a job at a pizza place because they can get paid more working in a pizza place versus what is really a skilled placement, but at minimum wage. So you could have a state minimum wage rate for that provider, that employee of a provider, but be in a region where there's a higher minimum wage based on a local ordinance, for example, San Jose or Los Angeles, where the market may draw skilled employees from the vendor sites, the provider sites, away from providing that service. So again, as we look at the economics of this, I think it's important to look at it in the broader regional economics that affect the ability of vendors to continue to provide the service in certain communities. So thank you for that clarification.
Was there, I believe there was a question you were going to try to get answered. I don't know if there's any of the department heads that are here that can answer your first question at all or not?
Maybe
Certainly.
Director Lightborn.
Will Lightbourne, Director of the Department of Social Services, to a couple of Senator Monning's questions regarding sort of the effect on potential nursing home costs, as Ms. Navarro observed. There aren't hard estimates that we've ever seen that are fully cooked. However, one of the features of the IHSS program is its sort of structure based on what we call the Community First Choice option component under the Affordable Care Act. That is, by definition, people who would otherwise qualify for nursing home admission, and that's about 43% of the overall caseload. It's significant to us also because when she was describing our attempts to maximize federal revenue, that 43% receive a higher federal matching share of revenue. So, but it's defined by nursing home, meeting nursing home criteria. In terms of the percentages of the providers at different wage levels, we have just slightly shy of 400,000 IHSS providers in the state. I would say the majority are probably above minimum wage. 130,000 of the providers, for example, are in Los Angeles County at currently $9.65 an hour, and they've just entered into a new labor agreement that increases that in the future. And then there are another significant group of providers in the Bay Area counties, which typically range above the $10 an hour payment. So I would say probably less than a half minimum wage at this point.
Thank you, Mr. Chair. Appreciate those clarifications.
Thank you. We have Senator McGuire, then Senator Morrell, and then Senator Mitchell. I did get you the question. So we'll start off with Senator McGuire.
Thank you so much, Mr. Chair, and do appreciate you bringing us together, and thank you for all the hard work as well coming into the hearing. I just have a few questions here and some statements, and do appreciate Mr. Lightbourne for being here and for the presentation by Mr. Martin. And I just want to start out with where the governor wanted us to go, and then just get some increased definition of that. Because what my understanding is from the proclamation that was issued is that wanted us to focus on increased oversight and effective management of services provided to consumers with developmental disabilities through the regional center system. I just want to get an understanding what that means. Because what it comes down to is we've lost hundreds of vendors. I think it was 300 vendors over the last 2 years that have been providing services. Maybe this is directed to Mr. Lightbourne, and again, I just want to say thank you to Mr. Lightbourne, and I apologize about the awkward. See, it's nice to see him. We could shake hands. But just what would you hope to be able to get out of this extraordinary session? Because I think one of the biggest stresses on the system is the issue of reimbursement rates. So if we can talk about that here a bit, because I just didn't see that within the statement.
Senator McGuire, I'm Mike Wilkening, Undersecretary of Health and Human Services, so I'm going to take that question. As I noted in my introduction to the session, so the governor called this, and for many reasons. One is to find permanent sustainable funding to replace the MCO that we're going to lose.
So I'm very familiar with that. Okay, I'm looking at DDs.
So for the DDS, there's a piece here where we talked about having rate increases relative to Medi-Cal and developmentally disabled providers. We also said that if we're going to invest more in the system, we want to make sure that the funds that are being put into the system are being used effectively. So that's the portion relative to the oversight of the regional center system. And there are regional centers that are having problems right now. We have inland and Kern regional centers where we have significant problems with the way that those centers are currently operating. So we want to make sure that if we're going to put money into the system, that it's being used effectively.
No, and I appreciate that. And, the reason I ask is because the task force, and I know we have two that are tracking, but isn't that one of the goals is to be able to look how those dollars are being spent at the regional center level, correct?
Right.
And then what we had heard from Mr. Martin is we're not expected to hear what their findings are to end of the year or potentially first thing in 2016, correct?
Right. The task force itself is probably not going to finalize its recommendations right now.
So I just want to, and I'm not trying to be crunchy here, but what I also don't want is to set ourselves up. and I want to talk about expectations. So if the task force is charged with figuring out exactly what dollars are being spent and how the regional centers are spending those dollars out in the community, and in this special session, we're supposed to be having that same conversation, but we're not going to hear the conclusion of the task force until the end of the year or first thing in 2016. How are we supposed to do our job here?
Well, so the task force has some areas where they've reached agreements, and so we can probably come back and talk about conceptually where the task force thinks that we should be focusing and looking at the rates. The legislature also, in both houses, had passed rate increases for the system. Those are good starting points for us all to look at and say, you know, is that where we should be focused?
Well, I guess, and again, I'm not trying to be crunchy, sir, and I know you're the messenger as well. So, so the legislature did pass modest rate increases, which were rejected. So the legislature brought forward modest rate increases that were rejected in years past. Also was rejected was DDS makes for revising community services rate structures. Got it. And so I want to make sure that we're going to.
I would just clarify, Senator. Okay,
I'm not finished. I want to make sure that we are focused on what I believe, and I think that you're going to hear a lot of feedback from many in the legislature, are those reimbursement rates. So if the work is not going to be completed until the end of this year or first thing next, that's a problem. So how are we supposed to do the job if the individuals that are going to be developing the recommendations aren't going to be bringing forward the recommendations until after the special session is completed?
I think there's a lot of information out there that we can use to have discussions about rates.
Okay.
I would clarify that the legislature didn't actually pass as a body the rate increases for DDS, that instead that those were each house had developed those, the conference committee did. The ultimate budget did not include those that came down.
And I guess my understanding is the legislature did propose and the administration objected to modest rate increases over the past 2 years. Am I incorrect with that?
There was discussions around that. I'm not recalling the exact.
All right. So I guess, and again, I appreciate your patience. I just want to make sure that if we're going to actually talk about rate increases, I want to make sure that there's clear expectation that we're going to actually be able to get some type of conclusion and potentially look at some relief. Because, and I want to get to my second point, and this is specific to to developmental centers. So the $46.7 million that's been put into the budget will increase bed capacity by 200 for community-based programs, and it's mostly going to be focused in the Sonoma Developmental Center because that's first on the closure list.
So the $46 million that was put in was an augmentation to what's already in the budget on a normal basis for community placement plan funds. So community placement plan funds develop resources for the system as a whole. They have been focused in the recent past relative to the closures. So Lanterman, for instance, was getting most of the, but there was the augmentation of $46 million specifically relative to Sonoma's closure. So it's in addition to what's in there already.
Absolutely. What my understanding, and I do appreciate the budget sub-chair who allowed me to sit in that meeting, is that original allocation was going to be spread out throughout the state. What the $46 million is going to be focusing on is mostly on the Sonoma Developmental Center since it's first on the closure list. So I just want to get to the point of, then we hear from the federal government that they want to be able to look at a year, if we're lucky, maybe a 2-year timeline related to closure. We have not closed a developmental center in this state in less than 5 years. We have the money that's allocated this year that would only house 200 residents. And as Mr. Martin had noted, some of the most medically fragile in the system. So I just want to make sure that we're not making arbitrary decisions based off of a deadline when our focus should be, and I know Mr. Rogers has agreed to this and do appreciate all of Mr. Rogers' time, is making sure that the health and well-being of the residents are taken care of first, and not just focusing on what I'll use my own editorial as an arbitrary deadline. We're talking about people's lives, and I just think that it's going to take additional dollars and time to be able to do this transition correctly.
And the health and well-being is going to be the paramount concern. The proposal from the administration, which is in the budget, is that we would do a closure plan by October 1st. We will do that, and that's going to be a very comprehensive process. Out of that process, we'll come up with what the ultimate closure date of Sonoma Developmental Center will be. The federal government, in the agreement that we just signed with them relative to Sonoma Developmental Center, honestly, the federal government will tell you that closures stay open. They aren't pushing that, but they are only going to provide the funding, federal funding, in increments of 1 year for the next 2 years.
Absolutely.
And then there's a potential for a reopener in November 2016 if we're in substantial compliance.
Absolutely. No, and I appreciate that. And again, I know that the Secretary has been working day and night on this along with Mr. Rogers, and I appreciate that. My last item on this, on the closure piece, is we are finding, my understanding, it's been a challenge to be able to find vendors to be able to participate within the regional center system. And in fact, we've actually been losing vendors because of the issue of reimbursement rates. And now we are closing additional developmental centers that are going to take, we're going to need additional vendors to be able to house those medically fragile individuals. And we're expecting them to do it on a rate that we can't even keep vendors who are currently offering services in the system, they can't stay afloat. So I'm concerned that we're setting ourselves up for some serious heartache if we can't keep vendors in now, and now we're trying to expand capacity.
And I expect that will be a subject as we go through the special session of what is necessary to maintain the system.
Absolutely. And I know it's going to take additional dollars. I just want to make sure that legislature and administration are working together and really focusing on those rates, because I think it is going to be a challenge to be able to attract more folks into the system to be able to provide the services if we're at our status quo reimbursement rate.
And in calling for the special session, the governor said open to a rate discussion both in Medi-Cal and in DDS. Okay. But there isn't a particular proposal that the administration has relative to rates for DDS.
All right. I do appreciate it, and again, not at all trying to be crunchy. I appreciate your patience. It just it's of serious concern as we move forward. So thank you so much.